A 39-year-old male presents to the ED with acute vision loss in his left eye. The patient stated, "I was doing computer work earlier today and all of a sudden my vision became fuzzy. When I close my right eye in the waiting room, it's like I see red people." He put a few drops of the redness reliever eye drops that he had laying around, but it didn't help. He denies recent surgery or trauma, and he said he's never had anything like this before, but did state that his vision in both eyes has been a little bit off for the past month, but he thinks it's from all the computer work he's been doing because he's trying to get his startup off the ground. In addition to the vision loss in his left eye, he also reports floaters, but no flashes of light, curtains, or veils. And he hasn't noticed any other symptoms. No eye pain, burning, foreign body sensation. There's been no discharge, itchiness, or photophobia. And as far as his past medical history, he's not aware of any medical problems and says that the last time he received medical care was back in college for strep throat. No pertinent ocular history, and on family history, states that his mom has a history of hypertension and coronary artery disease, and his dad has diabetes for which he receives eye injections. He's a busy entrepreneur who spends most of his time in his computer working on a startup, which he says he'll tell you about later on if that's cool. He also delivers food on the weekend to help bring in some extra income and will often pick up a meal for himself at the end of his shift, so that way he doesn't have to worry about cooking. On exam, his blood pressure was elevated at 140/93. The rest of his vitals were within normal. He's 5'10", weighs about 226 pounds, and you notice that there's an increased distribution of fat in the abdominal area. The eye exam, starting right to left, the visual acuity in the right eye was 20/60, which surprised the patient, but it did improve to 20/40 with pinhole. The anterior segment exam showed what looked like a mild cataract. The rest of the exam was unremarkable. For the left eye, the visual acuity was significantly worse. The patient couldn't read the eye chart and could only detect hand motion, and there was no improvement with pinhole. If you want to see how to check confrontation visual fields using your hands when the vision is pretty poor, check out this video next. The anterior segment exam showed a mild cataract but was otherwise unremarkable, including no visible iris vessels. Using a direct ophthalmoscope, the right eye was found to have a normal red reflex, and there was a clear view to the optic nerve which looked normal. There was no edema, cupping, or pallor. But on the left eye, the red reflex was dim, and when trying to look at the optic nerve, it was nearly impossible. There was no view, which was a stark difference from the right eye. An ultrasound of each eye was obtained, and for the right eye, it was unremarkable. But for the left eye, it showed significant vitreous debris that moved as the patient moved their eye. There was no retinal detachment or mass. You ask the patient about the floaters again, and he says they look like reddish strings. So let's take a step back. Acute painless vision loss, and that's really important that there's no pain because that'll help with the differential. Vitreous opacities on ultrasound, a dim red reflex, there's something interfering with the light passing through the eye. Red strings, floaters in his vision. Anytime someone describes red in their vision, think blood. And in this case, a vitreous hemorrhage. Vitreous hemorrhage is where there's blood in the vitreous cavity, and that can occur due to abnormal blood vessels, like in a pathology, or there's some force that leads to a rupture of blood vessels, like in a trauma. The vitreous is a large, clear, gel-like cavity that fills the space between the lens and the retina. There are many causes like a retinal tear, detachment, surgery, a neovascular cause, bleeding disorder, even retinopathy of prematurity. But a few that I'm going to highlight here are generally more common. Proliferative diabetic retinopathy is a common cause of vitreous hemorrhage. When there's blood vessel damage from diabetes, that can lead to retinal ischemia. That hypoxic state can lead to a release of angiogenic factors like vascular endothelial growth factor, which leads to new blood vessels via neovascularization to try to help solve the hypoxia. But these new blood vessels are abnormal, fragile, they grow where they shouldn't, and they're leaky. So basically, they're problematic. Trauma is a common cause of vitreous hemorrhage, especially if the patient is younger and does not have a history of diabetes. In a trauma setting, there's some force that ruptures a blood vessel. So that could be in a blunt trauma, full thickness laceration like an open globe, or shaken baby syndrome in a non-accidental trauma. Another condition to highlight is acute posterior vitreous detachment, or PVD. And this is where the vitreous detaches from the retina. It's a normal process of aging, and it's a common cause of floaters as well as flashes of light. So whenever there's, just as an aside, I get a consult about flashes and floaters, depending on the age, if the patient's 60s, 70s, 80s, it could be a PVD, but we want to make sure that there's not retinal pathology like a retinal tear or retinal detachment. As the vitreous is detaching from the retina, if it tears a retinal vessel in the process, it could lead to blood entering into the vitreous cavity, leading to a vitreous hemorrhage. So that's called a hemorrhagic PVD, and that actually increases the risk of a retinal tear or detachment. For symptoms, patients often have some vision change like blurry vision. The severity can vary depending on how big the bleed is, and if it is a big bleed, it could lead to a significant vision loss like a visual acuity of 2400 or hand motion in this case. The patient can also have floaters. The vitreous is cleared to allow light to pass through to the retina. When there's blood in the vitreous, it can form strands or clumps, which then cast a shadow on the retina that moves as the eye moves, and this can lead to the appearance of floaters in the vision. And if there's a mild bleed that's mainly inferiorly, a patient may only have floaters and the vision may overall be pretty good. There may also be a red color change or tint to the vision, and the patient may describe having red floaters or red strings that move as the eye moves. On exam, the visual acuity can decrease from the patient's baseline, again, the degree of which can vary. Intraocular pressure is often normal, but it could also be elevated, especially if the red blood cells start to clog the drainage angle of the eye. The appearance of the eye can vary depending on the etiology. So you can walk into a patient room and the eyes look completely normal. But if it's a trauma setting, you could have anything and everything: eyelid edema, ecchymosis, chemosis, hyphema, etc. If the underlying cause is neovascularization, on slit lamp exam, look for neovascularization of the iris, abnormal blood vessels on the iris, or even a hyphema that could result from those iris vessels that are fragile and leaky that could then bleed and form a hyphema. And seeing neovascularization of the iris, hyphema, in a non-traumatic eye, that could be a clue of posterior pathology like neovascularization from diabetes, chronic uveitis, as well as the many other causes of neovascularization. Using a direct ophthalmoscope can be used to check the red reflex, which is a quick assessment to see if there's something interfering with the light as it passes through the eye and vitreous cavity to the retina. So a normal red reflex, the light can easily pass through the clear media and you see a nice red reflex. But if you're seeing asymmetry, and especially if the reflex is dim, that could be a clue of a dense cataract or a vitreous opacity like a vitreous hemorrhage. Doing a dilated eye exam is helpful and important, especially in situations where there's acute vision loss. But it can be difficult if there's a vitreous hemorrhage because it can obscure the view of the retina. And this is where it can be really helpful to do an ultrasound like a B scan. And the main goal here is when you can't see looking in the eye because there's so much blood everywhere, an ultrasound can at least help to rule out obvious retinal pathology like a large retinal tear, retinal detachment, or a mass like a tumor. And it can also help to support the working diagnosis of a vitreous hemorrhage if you see a lot of vitreous opacities that move as the eye moves. So what do you do if you suspect a vitreous hemorrhage? Start with the routine eye exam to see does the presentation fit a trauma or a non-trauma, and of course the history is going to help with that. And look for evidence of neovascularization, like on the iris, so neovascularization of the iris. That could be a clue of posterior involvement and potential causes. Do a dilated eye exam pending your specialty and comfort level. And a key is doing the ultrasound, especially if you're seeing the patient in the ED. That's going to be really helpful in vitreous hemorrhage cases. Keep the head of the bed elevated so the blood can start to settle. And get the patient plugged in with an ophthalmologist to be seen as soon as possible. What to do if a patient takes a prescription blood thinner? I take things case by case and generally have the patient continue their prescription blood thinner if they're taking that due to an underlying medical problem. I don't routinely abruptly stop the prescription blood thinner. Now, if a patient takes non-prescription blood thinners like fish oil, ibuprofen, non-prescription aspirin, like just because, then I'll generally counsel the patients to avoid non-prescription blood thinners. Let's get back to the case. The patient was found to have uncontrolled diabetes with a hemoglobin A1C of 11.2 and a blood glucose at 283. The patient was adequately treated in the ED and will establish care with a PCP for further blood pressure and diabetic management. The patient saw an ophthalmologist in clinic later that afternoon. In the dilated eye exam, the right eye was evident of diabetic retinopathy, and the left eye confirmed a vitreous hemorrhage, but there was no view of the retina, so a B-scan ultrasound was done, and that ruled out a retinal detachment and mass. The patient was diagnosed with a left vitreous hemorrhage suspected to be due to proliferative diabetic retinopathy. Diabetic retinopathy of the right eye, as well as bilateral cataracts presumed to be due to uncontrolled diabetes, and this was likely the cause of the decreased vision in both eyes that the patient noticed over the last month. For management, because the ophthalmology exam wasn't evident for anything that needed urgent treatment or surgery, the main goal is improving the diabetes, blood pressure, and cholesterol control, and establishing care with the PCP as soon as possible, as well as vitreous hemorrhage precautions, which I'll list here. The patient was also counseled on strict return precautions. The patient will soon follow up with a retina specialist for further diabetic retinopathy workup and management. In summary, a vitreous hemorrhage can lead to acute unilateral painless vision loss, and the degree of vision loss can vary. It can be mild if the blood is minimal, or if it's already settled inferiorly and especially not obscuring the macula, but it can also be pretty severe, especially in a new bleed. There are many causes, with proliferative diabetic retinopathy being a common one, and a vitreous hemorrhage may be the presenting sign of diabetic retinopathy or diabetes in general. So consider labs, getting a hemoglobin A1C, blood glucose, and further diabetic workup in situations similar to this. The vision may be described as blurry, seeing red floaters, red strings, or red blobs. And in a patient with diabetic retinopathy, it's important to optimize the vascular risk factors, diabetes, blood pressure, cholesterol control, etc. Vitreous hemorrhage is just one of many diagnoses that can cause acute painless vision loss. But what about when it's not due to a vitreous hemorrhage? Well, I came up with a mnemonic that I still use. And you want to learn that helpful mnemonic? Check out this video.